My mission today is to summarize the result of the clinical studies which investigated the effects of the sperm alpha on lipid and glucose metabolism in patients with type 2 diabetes and hypertriglyceridaemia, which we recently published. And this slide adapted from the IDF Diabetes Atlas. Probably it's needless to say that the diabetes is the global emergency affecting the nearly 425 million people as of the 2017, and it's still a number is increasing. And it's impressive to see that the Western Pacific region is has the most highest number of the patient, nearly 3 times higher than the European, probably because the population is large, because this region includes China, and also probably another reason is the Eastern Asian people is more vulnerable to the obesity associated with the diabetes. But I need to stress that the diabetes is a very, very important risk factor for the vascular diseases, the macrovascular and microvascular diseases. So this is a very important thing. So probably it's also, everybody knows that the diabetes mellitus is a major risk factor for the cardiovascular diseases. And this is the results from the data of the Japan, JDCS Japan, the diabetes complication studies, which started nearly 20 years ago by the Yasuo Kanuma and Dr. Yamada, and followed by Dr. Sone. And this study included nearly 2,000 patients with diabetes and follow up nearly 10 years. And this study shows that the hyper-TG is the most important risk factor for the coronary heart diseases. In addition to this, there is the interesting synergism between other risk factors like the body mass index and hemoglobin A1C and systolic blood pressure and LDL cholesterol. So total of the triglyceride and body mass index and triglyceride and HbA1c and triglyceride and systolic blood pressure and triglyceride and LDL cholesterol. So the patient with the both triglyceride and other risk factor has the higher incidence rate for the coronary heart diseases. So the aim of the study which I'm going to show is to investigate the effect of the pemafibrate on the patient with type 2 diabetes and hypertriglyceridemia. It's a multi-center double-blind randomized placebo-controlled design, and inclusion criteria is the patient aged 20 or more, men or postmenopausal women, and hemoglobin A1c more than 6.2, and fasting triglyceride more than 150 milligram per deciliter, and a patient who takes the insulin or T2D or biguanide and high-dose SU, or SGLT2 inhibitor, or taking 3 or more anti-diabetic drugs, and people who exceed whose hemoglobin A1c more than 8 or whose fasting TG more than 100 are excluded. And primary endpoint is the fasting triglyceride and adverse events and adverse drug reaction. And we did the blood test here before the treatment and after 24 period to collect the blood for the HPLC analysis, and also we perform the meal test. So it's a kind of cookie which contains both three major nutrients: fats and carbohydrate and the protein. The fat is 30 grams, mainly from the butter. It's a meal test to see. It's sold by the Salaya in Osaka. A company, a small company, okay. And the patient is assigned to the 3 arms, placebo and pemafibrate 0.2 milligram per day and pemafibrate 0.4 milligram per day and follow up for the 24 weeks. And this is the baseline characteristic of the patients. And total of the 166 patients were allocated to the 3 arms. Okay, the mean age were 60 and more men, more than 70% men are recruited. And average BMI is 26, and 60% have the drinking habits, and 2/3 are hypertensive, and 2/3 has fatty liver. And the mean duration time of the diabetes is 5.7. And this is the background the drug therapy. It's nearly 45 patients were taking the 1 or 2 anti-diabetic drugs, and mainly the DPP-4 inhibitors. Probably 30% of the patients take the DPP-4 inhibitors. And this is the third slide, and nearly 40% patients took the statins, and there's the lipid and glycemic parameters shown here. And so average hemoglobin A1C at 53 millimole per mole, and the eGFR average is 74 or something like that. All right, the results. Okay, this is the result of the trend of the triglyceride. You can clearly see the reduction, significant reduction of the plasma TG in the both PEMA 0.2 group and 0.4 group. Let's see, it's a similar reduction. And at the time of the 24 weeks, it's minus 11% for the placebo, okay, and minus 44% for 0.2, and minus 45% for the 0.4 PEMA fibrate. Okay, this is the results for the other lipid parameters, and no significant change in the LDL cholesterol levels. Okay, and slight increase of the HDL cholesterol, especially in group of the 0.2 milligram, and reduction of the non-HDL cholesterol, especially in 0.2. And remnant cholesterol level is decreased by 50%. Okay, okay. This is the results of the apolipoproteins. So A1 is increased. ApoB is the decrease only in the 0.2 milligram groups, and ApoB48 decreased by 50% in both groups, and ApoC3 decreased by 30% in both groups. Okay, and we also perform the HPLC analysis. So we use the HPLC to subfractionate the LDL lipoprotein particles into the 4 subclasses, and also we subfractionate the HDL particle to the 5 subclasses, so depending on the size. And PEMA fibrate decrease the small and very small LDL, but it increases the large and medium-sized LDL. And in terms of the HDL at the PEMA fibrate increase the medium and small and very small HDL, while it decreases the very large HDL. And I think there is a significant difference between the 0.2 and 0.4 PEMA fibrate group. Okay, next I'm going to show the results of the glycemic parameters. You can see the fasting plasma glucose levels that looks like it's decreased, and fasting insulin is decreased, and the HOMA-R index is decreased, and the HbA1c increased from the baseline. But by the pre-specified statistical analysis, the only significant difference was observed in the change in the HOMA-R. So the other statistics was performed an ad hoc post-analysis study. So probably one thing which we can say is the 0.2 PEMA reduced the HOMA-R, insulin resistant index, in a patient with the type 2 diabetes in this population. So probably this alleviation of the insulin resistance may be primarily caused by the increase of the FGF21. It's already mentioned in the previous session. So it's insulin sensitizing hormone secreted by the liver in the starvation, the fasting condition. It's also a target of the PPL alpha. So probably this increase of the FGF21 causes alleviation of the insulin resistance. So next, that I'd like to show the results of the meal tolerance test. So it takes the blood before and 1 hour and 2 hour and 4.5 and 5.5 hour after the intake of the meal. We collect the blood and measure the plasma TG and glucose and insulin. And placebo is no difference. And in PEMA 0.2 milligram group, there is a significant reduction in AUC and area under the curve. Okay. And also PEMA in the group of the PEMA 1.4, there is a significant decrease of the AUC for the triglyceride excursion. So next is the result for the glucose levels. So you can see the nice increase of the plasma glucose, but the PEMA fibrate didn't have any effect on this plasma AUC of the plasma glucose. Okay, insulin level is increased after the ingestion of the meal, but there is no effect of the PEMA fibrate on the plasma insulin levels. Okay. The last way I'd like to show the side effects. So we have the several patients complain of the adverse events, but there's no difference, very similar across the 3 groups. But you can see the 4 patients have the adverse events leading to discontinuation, and 2 of them the association with the drug can't be ruled out. One patient has probably acute kidney injury, and the other one is some severe Rebar dysfunction. So that association can't be ruled out. Okay, but otherwise it's very similar across the study patients. And this is the results of the Rebar function test. So we already discussed that the PEMA fibrate is in contrast to the phenofibrate, it's the fibrate group. The PEMA fibrate reduces most of the liver enzymes from the baseline. In particularly, alkaline phosphatases, there is the nearly 90% reduction from the baseline levels. Okay. And this is the result for the kidney function, the eGFR and serum creatinine. You already know that the phenofibrate increase the plasma creatinine levels by 50 or 100%, but PEMA fibrate didn't have such effect. Okay, no effect on the plasma creatinine in this dose range. So in conclusion, so PEMA fibrate significantly reduces the fasting serum triglyceride levels by 45% compared with the placebo, at least in the beginning. Okay. And PEMA fibrate significantly reduces the non-HDL environment and ApoB100 and B48 and C3, and significantly increase the HDL cholesterol and A1 levels. Okay, and 0.2 milligram per day PEMA fibrate significantly reduces the HOMA R compared with placebo. However, no significant changes compared with the placebo found in fasting plasma glucose and insulin and glycoalbuminemia or HbA1c levels. So the rate of the adverse events was comparable. So PEMA fibrate is very efficacious in ameliorating lipid abnormality and well tolerated in patients with type 2 diabetes and dyslipidemia. This is our conclusion. So next, this is the results that the adopted from our first report on with Calida out on the just dyslipidemia and no diabetes. So we measure the HOMA R, and you can see the reduction in decrease of the HOMA R in the patient who took the 0.2 milligram, but not who took the 0.4. Okay, this is very similar to the previous results. So in order to know that the why HOMA R is improved in this specific population, we performed the hyperinsulinemic glycemic clamp study So in the patient who have the hypertriglyceridemia and some of them have diabetics and the other didn't have the diabetes, and measure the hepatic glucose uptake rate and peripheral glucose uptake rate. And so we allocate the patient to the placebo and the pemafibrate this time of only 0.4 milligram per day and followed for the 12 weeks. So, and this is the machine which artificial pancreas to study to measure the hepatic glucose uptake and peripheral glucose uptake. So probably traditionally, hyperglycemic and euglycemic cramp study was developed by the Dr. Deflonzer at the UT San Antonio, who used the tritium glucose and catheterization to the hepatic vein. It's very too complicated for us to do, so we simplifies his method to just give the oral glucose during the period and see the changes of the glucose infusion rate to obtain the hepatic glucose production. This is the background parameters. Okay. And this is the results. So you can see there is a significant increase in the hepatic, actually the splanchnic glucose uptake in pemafibrate 0.4 milligram groups. So very significant from the baseline, but the difference from the placebo is not is insignificant. So peripheral glucose uptake, there's no significant difference. So in the literature, probably bezafibrates and T2D stimulate the peripheral glucose uptake. So the reason for the bezafibrate and the T2D improves the glucose intolerance, glucose resistance by stimulating to the peripheral glucose uptake, but this PPLR specific ligand increase the hepatic glucose uptake. Okay, probably this may be because the FGF21. So we hypothesize that the involvement of the potential substance which potentially affect the insulin sensitivity, so fatty acids, and the FGF21 and adiponectin. So we measure all of them, but actually the adiponectin has no change. Okay, and FGF21 it's increase like this, and fatty acid slightly decreased, but in the literature, fatty acid is involved in the determinant of the skeletal muscle insulin resistance, and not the liver. So probably FGF21 is the important regulator, mediator to alleviate the insulin resistance in patients who treated with the pemafibrates. Okay, in conclusion, the pemafibrate improved insulin resistance primarily by increasing the splanchnic glucose uptake, and increasing plasma FGF21 might contribute to the improvement of insulin resistance. So this work can be done without the support from these collaborators and many other clinicians and also patients. And in particular, it appreciates the Jean-Charles and Dr. Kodama, and now it's the Dr. Yamashita and Dr. Yokode here. Okay, and lastly, probably Dr. Yamashita will present this. This is the kind of the advertisement. So Dr. Yamashita will chair the ISA meeting at Kyoto in 2021. So don't forget this. Okay, thank you.